Hello, my friends. It's Dr. Sharon with Clinic Reviews. I got a request to do ulcerative colitis and Crohn's disease, so that is what I'm doing today. It does happen to be in the Blue Book, but I'm going to take it a little bit beyond what the Blue Book talks about. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews. Thank you for being a part of our Clinic Review family. I've got the dogs in here with me today, so you may occasionally hear a squeaky toy or some barking. I'll try to cut it out if that happens. So Clinic Reviews is the home of the very best NCLEX review in the entire universe, in my opinion. Mark Klimek is the absolute GOAT of NCLEX reviews. You can get our 21+ hour NCLEX prep course online on demand. Mark Klimek teaches it himself. Go to clinicreviews.com. We also have a streaming service, and we have monthly tutoring, small group tutoring packages. So those are all available at clinicreviews.com. So today we're going to do Crohn's disease versus ulcerative colitis. There is some information about it in the Blue Book. You can see the Blue Book there behind me. I'm going to assume that you have already studied that. It's real fundamental, just fundamental facts related to that. So I'm going to take it a little bit past that. I'm going to do some prioritization questions, some SATA questions related to this, since I got a special request to do ulcerative colitis and Crohn's disease. So let's go ahead and get started. A 34-year-old patient has just been diagnosed with ulcerative colitis. Which teaching points should the nurse include about this condition? It typically involves the entire thickness of the bowel wall. It usually starts in the rectum and extends proximally in a continuous manner. You may notice frequent bloody diarrhea. Smoking cigarettes often worsens ulcerative colitis. You are at increased risk for colorectal cancer. Ulcerative colitis can affect any part of the GI tract from mouth to anus. So ulcerative colitis and Crohn's disease are considered inflammatory bowel disorders. They're also autoimmune disorders. Autoimmune means the immune system is attacking me for some reason. So my immune system is set up to attack something that's not me. Anything that gets into my body that's not me, self versus non-self. So anything that's non-self, the immune system is supposed to attack. When the immune system starts attacking self, that's called autoimmune disorder. So these two disorders, they're inflammatory and they're caused by autoimmune. So the immune system is attacking the bowel, the colon. And I always get these two mixed up. So I don't know how you're going to remember it. I don't have a special way to remember it. However, ulcerative colitis is from rectum on up. So it starts in the rectum or in the anus and it moves up in its disease, its inflammation and all that, okay? Now, Crohn's disease can be anywhere between the rectum and the mouth. So anywhere in the GI tract between the rectum and the mouth, and it has what's called skip lesions. So it doesn't have to occur in a continuous manner. Ulcerative colitis occurs in a continuous manner, whereas Crohn's disease has skip lesions. So that's the primary difference between the two, except that Crohn's disease also tends to involve all layers of the GI tract, which means they're more prone to scarring and fistulas. Fistula is a hole where God did not put a hole. Okay, so my nose is not a fistula. My mouth is not a fistula. If I all of a sudden develop a hole in my cheek and I didn't put it there, God didn't put it there, that's a fistula. Okay, so the problem with having all of the bowel, all layers of the bowel wall being affected is you can develop a hole in there and some of the contents can leak out. So that is more prone to happen with Crohn's disease. A 34-year-old patient has, okay, so we've got the diagnosis. So which should you include related to ulcerative colitis? Okay, it typically involves the entire thickness of the bowel wall. No, that's Crohn's disease. It usually starts in the rectum and extends proximally in a continuous manner. Yes, that's ulcerative colitis. You may notice frequent bloody diarrhea. Yes, very much so. It can occur with Crohn's, but ulcerative colitis tends to have more bloody diarrhea because it starts distally. It starts in the rectum and the anus, and so you have more bloody diarrhea with ulcerative colitis. Smoking often worsens ulcerative colitis. Look, I would say smoking exacerbates just about anything, and it particularly would exacerbate anything that has an inflammatory component to it. Nicotine and all the things that you inhale in the cigarettes all have inflammatory components to it. And it doesn't just affect the lung, it affects other organs where this stuff is filtered out, and it can cause inflammation. So I would say smoking would worsen anything that's inflammatory. You're at increased risk for colorectal cancer. So I would definitely say yes. So we know ulcerative colitis starts in the rectum and moves up. So we have the correct position here. And it's inflammatory, and recurrent inflammation increases your risk for cancer really anywhere. Also, that's like why sunburns, continuous or frequent sunburns increase your risk for skin cancer, because it's inflammatory. Ulcerative colitis can affect any part of the GI tract from mouth to anus. That's not true. Now, I want you to notice that B and F are opposites. And in a SATA question, when you have opposites, one of those, you're going to have to probably pick one of those. Okay. So B, C, D, and E are the correct answers on this one. And this is just remembering which one is which. Okay. Ulcerative colitis, they're both inflammatory. They're both autoimmune, but Crohn's has the skip lesions and is more likely to have all layers of the bowel wall. So they're more prone to fistulas. The nurse is planning care for a patient with acute exacerbation of Crohn's disease. Which outcome is the most immediate priority? I would probably say the outcome, they're very similar. They present very similarly. We treat them very similarly. So other than just understanding the difference in the pathophysiology and the risk for fistulas, I would say we treat them the same. All right. So what's the immediate priority? Achieving normal bowel elimination patterns. I guess their baseline maybe, but I don't know. That doesn't seem like an immediate priority. Identifying coping strategies does not seem like an immediate priority. Ensuring adequate nutritional status, maybe. Restoring fluid and electrolyte balance. So I know that Crohn's is very prone to diarrhea, like a lot of diarrhea, like maybe 8 to 10 stools a day, especially during an acute exacerbation. It shouldn't be that often if you're not having an acute exacerbation, but with an acute exacerbation, they could have 8 to 10 diarrhea stools a day, maybe more if it's really severe. So immediate, if I go back to immediate and I say, am I more concerned immediately about nutrition, or am I more concerned immediately about fluid and electrolyte? And I have to say fluid and electrolyte is more of an acute problem, where nutritional status is more of a chronic problem. So immediately I'd be more concerned about the acute problem than the chronic problem. You don't become malnourished overnight. You can become fluid and electrolyte imbalanced overnight. Which medication class is most commonly initiated first in mild to moderate ulcerative colitis to reduce inflammation in the colon? Aminosalicylates, antispasmodics, proton pump inhibitors, immunomodulators. The correct answer is aminosalicylates. Sulfasalazine, this is a med you just have to memorize. It is the first-line drug of choice for the inflammatory bowel diseases. Immunomodulators occur later. If the sulfasalazine, the aminosalicylates don't work, then we can move to the immunomodulators. Remember, it's an autoimmune disorder. So if we have to suppress the immune system, then we have to suppress the immune system, but we don't do that first line at all. A patient with Crohn's disease is prescribed infliximab, a TNF inhibitor, which means it's a immune inhibitor. It's an immunosuppressant. Whenever you see a mab like that, whenever I see that word, even if it didn't say TNF inhibitor, infliximab, that MAB at the end, I always think that's suppressing the immune system. Which assessment finding requires priority follow-up before administering this medication? So history of seasonal allergies requires immediate follow-up before giving an immune suppressant. I don't see why. Mild peripheral edema would require immediate follow-up before giving an immunosuppressant. I don't see how that's going to affect anything. Positive TB skin test requires immediate follow-up before giving an immunosuppressant. Well, absolutely. Complaints of mild headache require immediate follow-up before giving an immunosuppressant. Mild headaches are common. That's not a problem. So I'm concerned about the risk for a deadly infection before giving him an immunosuppressant. A patient with Crohn's disease reports severe right lower quadrant pain. So right lower quadrant pain has rebound tenderness. The nurse should suspect which possible complication: bowel obstruction, toxic megacolon, pancreatitis, hemorrhoids. All right, right lower quadrant pain. So pancreatitis is out. The pancreas is not in the right lower quadrant. Hemorrhoids would be in the rectum, so that's out. So would I be more concerned about bowel obstruction or toxic megacolon? So toxic megacolon is associated with ulcerative colitis, and ulcerative colitis is from the rectum on up. And we're talking about right lower quadrant pain. That's not in the rectum. That's not in the that's getting pretty close to the small intestine. That sounds more like a skip lesion to me. And so I know that bowel obstructions can occur. In fact, one of the reasons they end up having to have a colostomy with Crohn's disease is they end up having bowel obstructions from the chronic inflammation. The scar tissue ends up obstructing the colon. So that is the correct answer. So bowel obstructions are more common with Crohn's disease, whereas toxic megacolon is more common with ulcerative colitis because it's that chronic reinflammation of the same area over and over and over, and it starts to weaken the colon wall, and you get what's called a toxic megacolon that nothing can really pass, has trouble passing through that area. Which nursing interventions are appropriate for a patient hospitalized with an acute exacerbation of Crohn's disease? All right, hospitalized with an acute exacerbation, monitor daily weights, encourage high residue foods to promote bowel motility, administer IV corticosteroids per orders, maintain strict intake and output records, provide frequent oral care if the patient is NPO, restrict fluid intake to decrease bowel frequency. Okay, so what do I want to do? I have a chronic inflammatory disorder. They're having an acute exacerbation. So I know they're having a lot of diarrhea. They're losing fluids. They're probably losing electrolytes. We want to rest the gut. So they probably are going to be NPO for a few days, which means they're going to be on IV fluids to restore any fluid imbalance. So knowing that's sort of the typical treatment, plus steroids to reduce inflammation. And then if they think there's an infection, they may have on an antibiotic if they think there's some infection associated with that. So let me reread these again. Monitor daily weights for an acute exacerbation of Crohn's disease. Well, I am concerned about fluid loss, so that seems like a good idea to me. Encourage high residue foods to promote bowel motility. Y'all, they're having diarrhea. We don't need to promote bowel motility. High residue foods are things like high fiber, and things that are harder to digest, actually. So the fiber is high residue, but I don't want to give fiber. I don't want to give fiber. In fact, fiber is not typically an intervention for the inflammatory bowel disorders because they already have a problem with diarrhea. Administer IV corticoids per orders. Yes, I like that because we give steroids for sure. And it says per order, so I like that. It's a good NCLEX answer. Maintain strict intake and output records. Well, yeah, they're having diarrhea and I can actually measure it. Fluid wise, I need to keep track of that. I need to know what's going in and coming out because they're at risk for fluid and electrolyte imbalance. Provide frequent oral care if the patient is NPO. They probably are NPO. We're resting the gut. And so, yes, absolutely provide frequent oral care. That's a good idea. Restrict fluid intake to decrease bowel frequency. No, we don't restrict fluid intake. We may have them NPO, but we're still giving them fluids through their IV. So those are what I would want to do acutely for inflammatory bowel disorder. Whether honestly, we do the same thing for ulcerative colitis. Which statement by a patient newly diagnosed with Crohn's disease indicates a need for further teaching? Further teaching means false. They make a false statement. I will need to monitor my diet carefully, especially during flare-ups. Yeah, they should have a low residue diet during flare-up. So that's true. Crohn's disease only affects my large intestine, so I don't have to worry about my small intestine. That's not true. Crohn's disease is rectum to mouth, and it has skip lesions, so B is a false statement. I may need vitamin supplements if my intestines can't absorb nutrients. That's true. I should notify my provider if I develop severe abdominal pain or fever. Well, absolutely, because they could have a fistula that was created. So I know I have a lot of questions where I'm asking you whether it's continuous lesions or skip lesions, or if it's just one small area, or it's all through the GI tract. And I'm doing that just because it's hard for me to remember. So I'm totally projecting on you. Is it hard to remember ulcerative colitis versus Crohn's? So I give you a lot of questions like this. When teaching a group of patients about the difference between ulcerative colitis and Crohn's disease, which points should the nurse include regarding Crohn's disease? It often presents with continuous lesions throughout the colon. continuous lesions throughout the colon. No, that's ulcerative colitis. Well, I'll just say which is which. This is ulcerative colitis. It can affect the entire GI tract from mouth to the anus. That's Crohn's. Fistula formation is common. That's Crohn's. Typically limited to the mucosal layer. That's definitely not Crohn's. That's more likely to be ulcerative colitis. And it's chronic reinflammation of that layer over and over again. Granulomas are frequently found on biopsy. So I had to look up granulomas, y'all. I did it for you. I did it because I love you. Granulomas are small clumps of inflammatory cells. That's what granulomas are. What are inflammatory cells? Well, they're all the immune system cells that come to they're trying to fix the problem. So they just call them inflammatory cells to make them easier to say. So granulomas, well, if it's an inflammatory disease, it seems like they'd have small clumps of inflammatory cells. That makes sense. It often involves skip lesions. That's Crohn's. So, and I would think, I don't know, which point should the nurse include regarding Crohn's disease? I would think E would be true for both, but it is Crohn's. It doesn't say which one is true only for Crohn's. It says which is true for Crohn's. So B is Crohn's, C is Crohn's, E is Crohn's, and F is Crohn's. All right. A 45-year-old patient with ulcerative colitis is at an increased risk for which long-term complication? Kidney stones, colorectal cancer, esophageal strictures, peptic ulcer disease. So I'm crossing off C and D because ulcerative colitis doesn't involve the esophagus or the stomach, whereas Crohn's could involve the esophagus or the stomach, but ulcerative colitis does not. So ulcerative colitis involves the rectum and continuous lesions going up, and we have chronic reoccurring inflammation. So that's certainly a risk factor for colorectal cancer. Kidney stones don't really have anything to do with this at all, so I'm crossing off A. The nurse is reviewing discharge instructions with a patient who has Crohn's disease and is going home on metronidazole therapy, which is an antibiotic. Which instructions should the nurse emphasize? Going home with Crohn's, taking metronidazole. So I don't know that much about metronidazole. So let's see what the answers are. Avoid all alcohol during therapy. Stop the medication once symptoms improve. Take the medication with meals to reduce GI upset. Report any numbness or tingling in your extremities. Maintain adequate fluid intake to support renal function. Expect your urine to turn red-orange color while taking metronidazole. Okay. I don't know any of these for sure, right? So when I don't know anything for sure, like I don't know anything specifically about metronidazole, I have to go generally. So I'm going to have to say, in general, what do we teach about antibiotics? Avoid all alcohol. Yes. Y'all, I always say avoid alcohol when you're taking a prescription med. So absolutely. A is true. Stop the medication when symptoms improve. Y'all, I never say that about antibiotics. Never. You take the antibiotic till the end. You take the whole prescription. So B is out. Take the medication with meals to reduce GI upset. Well, I do say that. I don't say take it with milk. You don't take it with fiber. You don't take it with antacids. So those are 3 things you don't take it with, but you can take it with meals to reduce GI upset. So I don't know if that's true about metronidazole, but I know it's true for a lot of things. And since I don't know specifically about metronidazole, I'm going to choose C. Report any numbness or tingling in your extremities. Well, y'all, if they have numbness or tingling in their extremities after taking that, I'm going to say, yeah, report it. That's unexpected. Maintain adequate fluid intake to support renal function. I don't know if metronidazole specifically affects the kidneys, but it's a good recommendation. Maintain adequate fluid intake in general. Since I don't know anything specifically about metronidazole, I'm going to say in general, is a good recommendation. Expect your urine to turn red-orange color while taking it. I don't know that, and it's not a general recommendation that I say. There's only one med that I know of that turns your urine red-orange color, and it's not metronidazole. I can't remember the name of it right off the top of my head. I'd probably recognize it if I saw it, but I can't remember it right off the top of my head. So F is not something I generally teach. So I teach A, I teach C, D sounds good, E sounds good. So I'm going to pick those. And those happen to be the right answers. So what I'm teaching you is how to answer questions when you don't know what the right answer is. When you say, well, I don't know, so I'm going to use my common sense and my clinical reasoning. Use common sense and clinical reasoning, y'all. I can't say that enough. What makes sense? It just makes sense. And you say, well, I don't know if it's true for this med, but it's true for an awful lot of meds, so I'm going to pick it. The nurse is caring for a patient admitted with an acute exacerbation of ulcerative colitis, which intervention takes priority. Encourage a high fiber diet. We already said no, that doesn't work. Schedule a barium swallow test. Barium swallow doesn't look for anything in the rectum and above. It tends to look for things like blockages more higher up. So I don't know why a barium swallow would help. Apply a warm compress to the abdomen. Y'all, ulcerative colitis is in the rectum and above, so an abdominal warm compress isn't going to help. Administer IV corticosteroids. Well, it's an exacerbation, which is an inflammation. So absolutely, I like that answer. Corticosteroids are standard therapy for really any autoimmune disorder. Rheumatoid arthritis is an autoimmune disorder. If you have a flare up, they're probably going to put you on steroids. Same with inflammatory bowel diseases. A patient with ulcerative colitis who's receiving sulfasalazine, which is the anti-inflammatory med, first line, asks the nurse about side effects. The nurse should include which points in the patient education. Another med I don't know much about. I know it's an anti-inflammatory and that's it. So if that's true, I'm going to go with general things related to side effects. General principles that I know to be true about side effects. Use sunscreen or protective clothing because this medication can increase photosensitivity. I don't know if sulfasalazine increases photosensitivity. Would an anti-inflammatory increase? Do I think an anti-inflammatory increases photosensitivity? That I don't know. But I do know that if it does, wearing sunscreen and protective clothing is the right recommendation. So I'm going to keep A as a possibility. I don't know that. It's normal for your skin to turn bluish, so don't worry. I don't like the answer. I don't like that answer says don't worry. And I've never, ever told someone their skin, you should expect it to turn blue. Like I've never told anybody that. That seems silly. So I'm not going to pick it. You may experience decreased urine output. That is harmless. Y'all, I have never told somebody decreased urine output is harmless. And if I'm going general, because I don't know much about sulfasalazine. So if I'm going general, I'm not going to tell them something that I've never told anybody before. D, it's important to drink plenty of fluids to prevent kidney stones. I tell people that. That seems like a good general thing to recommend. I don't know if sulfasalazine can cause kidney stones, but it's a nice general recommendation. Some patients experience headache and nausea. Okay, do you know what the two most common side effects of any meds are? Headache and nausea. Those are the two most common. So if I had to guess at the side effects, I would guess at the two most common, which are headache and nausea. So I like E. Call your provider if you have a rash or signs of an allergic reaction. Well, that's a good recommendation. All right. So I know F is good. I know E is good. I like D because it's just generally a good recommendation. I've never said B or C before. So now I have to say A. I don't know if I would pick it or not. I don't know if I would. If I were guessing, I don't know if I would pick it. I will tell you it's the right answer. So if you want to memorize it, sulfasalazine can cause photosensitivity and they should wear sunscreen or protective clothing, then go ahead and memorize that. Would I have picked it? I don't know. That probably would have been like a 50-50. My thing is if I don't know for sure that it's the right answer, and if I'm just trying to cover all my bases, I don't like to just cover all my bases with SATA questions because I tend to overselect anyway. So I probably would not have picked A if I didn't know for sure it was a right answer. So I'm just teaching you that, okay? Which factor in a patient's history is most likely to put them at higher risk for developing ulcerative colitis? Well, to me, it seems like it's a genetic disorder, but that I don't know. Age between 30 and 45, high dietary intake of protein, recent prolonged use of broad spectrum antibiotics, age between 15 and 30. So I've never heard of B or C being risk factors for an autoimmune disorder. And I have two answers that are opposite to each other. So when I have an answer that when I have a single choice question option, I don't know what the answer is, but I have two answers that are opposite from each other. I know one of them is probably right. I use this when I'm guessing. I don't use it if I'm not guessing, but when I'm guessing, I do. So if I'm guessing, do I think it's more likely to occur young or old? Well, I'm just here to tell you it occurs young. That's in the blue book. It's more likely to be picked up younger. Crohn's is more likely to be picked up probably in your 20s, but it's still kind of in that same age range. So these tend to be picked up in the younger years rather than the older years. During a flare-up of Crohn's disease, which diet does the nurse most commonly recommend? Low residue, high protein, high fiber, low fat, vegan diet with minimal protein, clear liquid diet for 2 weeks, then gradual increase to regular foods. During a flare-up, which diet does the nurse most commonly recommend? Well, I'm not going to recommend a vegan diet with minimal protein. That doesn't seem like a good idea. We're already concerned about their nutrition because with this inflammatory disorder that kind of goes through the entire GI tract, I know they're at risk for absorbing nutrients. So I don't like minimal protein. I don't like high fiber. I told you high fiber doesn't really help with these, so I don't like that. Low residue is the opposite of high fiber. So low residue is low fiber, no seeds, like no popcorn, no anything with a seed in it. You're not supposed to have any seeds. You're not supposed to eat anything that's hard to digest. So real stringy meats and stuff like that. That's all low residue. And then high protein, which is good for nutrition. Would I say clear liquid for 2 weeks? Clear liquid seems for 2 weeks seems extremely long because I'm already worried about their nutrition. So to do clear liquids for 2 weeks, I might be NPO for like a few days while they're in the only if they're in the hospital, and then maybe clears for like a day. But man, 2 weeks, that doesn't make any sense. So I like a low residue, high protein. That is the recommendation. Low residue really all the time. For patients, not just during flare-up. A nurse is caring for multiple patients on a GI unit. Which patient with inflammatory bowel disease should the nurse see first? Okay, I'm not going to read through all these to begin with. So whenever it says who should you see first, and sometimes it's a single choice option and sometimes it's multiple, you always see the unstable patient first, What makes a patient unstable? Well, I'll tell you two that I see frequently. Unexpected findings. So they have a disease, but the symptoms are not related. They seem either unexpected related to the disease or they indicate a complication. They're not just a general symptom. So unexpected findings or a new onset finding, something that just started. That makes them unstable. So let's see if that helps here. Patient with Crohn's disease complaining of mild crampy abdominal pain. That's an expected finding, so they're not going to be first. Patient with ulcerative colitis reporting 15 bloody stools in the past 12 hours. Yikes, maybe 15 and 24, but in 12? That's unexpected. Okay, that's unexpected. So I got to see B. Patient with Crohn's disease who has a temperature. That's unexpected. Elevated temperature is not associated with inflammatory bowel disease. That means they've got an infection going on somewhere. That's not expected. A stable patient with ulcerative colitis who's awaiting discharge, well, they tell me they're stable. Okay, don't pick the patient if they tell you they're stable. If it says they're unstable, you can pick them. A patient with Crohn's disease complaining of occasional belching. Well, Crohn's disease is through the entire GI tract, so okay, they're burping. Fine. That doesn't surprise me. Patient with ulcerative colitis reporting sudden severe abdominal distension and pain. That's all of us. That's sudden onset. That's always a concern. Okay, so I am going to see the unstable patients, all of which either have unexpected findings or sudden onset. If that isn't there, those options aren't there, you can pick the patient who was just admitted or just got back from the OR. Those, and I mean within like a few hours. A patient with ulcerative colitis reports new onset of fever. That's unexpected. Tachycardia. That's unexpected. And abdominal distension. That's unexpected. The healthcare provider suspects toxic megacolon. Which priority nursing actions should be taken? Toxic megacolon. All right. And not just toxic megacolon, but they've got symptoms that make me think maybe something ruptured. I don't really expect toxic megacolon to rupture, I'll be honest with you. But fever, tachycardia, and abdominal distension makes me think there's a fistula somewhere, like a rupture. I don't like that. So if I think there could be a rupture, what do I need to do? Assess for rebound tenderness and rigidity? Yeah, that's assessing further symptoms of rupture. Obtain vital signs? Absolutely. That's if I'm concerned they could have ruptured something, then I need to do that. Encourage high fiber diet. No, we're not doing that. No, don't do it. Administer IV fluids. Absolutely. As ordered, and especially it says as ordered. So yeah, that's a good NCLEX answer. Position the patient flat on their back. I've never positioned someone flat on their back when I'm worried about a rupture. Maybe on their side, maybe with the head of the bed up, but not just on their back. seems unusual. A patient with Crohn's disease is receiving TPN, which nursing responsibilities are critical when caring for a patient on TPN. Sharon, you tricked us. This is a TPN question. Well, sometimes Crohn's, ulcerative colitis end up on TPN for a little while. Checking blood glucose levels regularly. Yes, when they're on TPN, they are prone to hyperglycemia. They can be. So yes, we do get them. We usually, and when it regularly just means scheduled. So it's usually every 6 hours. Administering TPN through a peripheral IV line. No, we give TPN through a central line, not a peripheral line. Monitoring the infusion rate carefully. Yes, because if it goes too high, they become hyperglycemic. If it goes too low, they can become hypoglycemic. We got to make sure it's running at the right rate. And you never just turn it off. Like you have to wean it off. Maintaining sterile technique when handling the central line. All right. So that's sort of a vague answer. Maintaining sterile technique when handling the central line. So it's sort of a vague answer. And I don't use sterile technique every time I touch the central line, but I have to think conceptually, and I have to think, why are they asking me this? Well, they're probably asking me this because central lines put people at risk for infection, right? So you do have to maintain sterile technique whenever you're changing the dressing. And TPN is a high glucose environment, which means bacteria can grow in it really easily. So we're in a situation here where they're at high risk for an infection in this line. So even though it's sort of a vague question, I say to myself, I mean, there is a high risk for infection. So it seems like using sterile technique when handling the central line seems like a good idea. It may not be the policy, it may not be written that way exactly at your hospital. And maybe it doesn't say it exactly that way in your textbook, but it's like a good idea. And what I'm saying is I understand that there's a high risk for infection here because this is a high glucose environment right into a major vein. Change the TP bag and tubing every 72 hours. Okay. This is the wrong number. It's every 24 hours. So if you don't know, TPN has to be changed out every 24 hours. Tubing and everything. It's 24 hours, not 72. Assessing the patient's weight and intake output daily. Well, yeah. Anytime we're doing some change in the way we nourish a patient, it seems like it would be a good idea to do their weight and intake and output to see like how is their body handling this, right? Is their body retaining fluids? Is their weight going down? Is it not adequate? Like what's going on? So that's a good idea. So I like A, I like C, I like D, and I like F. Okay. So that was, could have been more comprehensive, I suppose, but it's a relatively comprehensive review for NCLEX purposes. Remember, this is an NCLEX prep channel. Also, if you're taking any standardized tests, it's preparing you to take standardized tests. You should have already had your lecture on this. This isn't intended to be your first exposure to inflammatory bowel diseases. So I hope it's helpful after already having been taught about it and now doing a review. I hope this helped, and I hope it helped you know how to answer questions. Success on the NCLEX does involve adequate knowledge, but most of you have the knowledge you need to pass. If you're struggling to pass, it's probably because you're reading the questions and incorrectly and or overthinking. Stop overthinking. Okay. So if you have a tendency to overthink, start adding into your lexicon saying, in general, I would do this. In general, I would do that. Because if you don't say in general, you tend to like go off on a rabbit trail. Go, well, I could do this. I heard about it this one time. I think I read it somewhere in a book. Okay. But in general, do you do it? Okay. All right. Well, I say that all the time, so I won't bore you by continuing to say it. I hope you have a great rest of your day, and I'll see you later.